is of a 57-year-old Caucasian man with a family history negative for GI neoplasms. The patient is a non-smoker and consumes 2 alcohol units per day. He has abdominal pain, but no weight loss. EGD plus biopsy showed a protruding papilla. Histology showed tubulovillous adenoma with high-grade dysplasia, and an MRCP showed a normal pancreatic duct with no dilation of the common bile duct or the intrahepatic ducts. This is an endoscopic view, and today's procedure is an EUS plus an ampulectomy performed by Dr. Costamagna and Dr. Petrone.
I am with the probe in the second part of the duodenum, and we are looking for this ampullary lesion. You can see here this small apoechoic lesion. Facciamo il busco, Panedo. It's quite rigid at elastography. You see here. And we can see also the common bile duct going inside the lesion, just in the papilla. This is the common bile duct with a very thin thickening of the wall. But the lesion is completely outside, so the muscle layer is regular here. We check the dimension. So it's 9 millimeters. When you have to study the papillary region, it's very important to release completely the tip of the scope, and you have to put inside a lot of water, so we are able to see the different layer of the duodenal wall, and in this case, the lesion that for sure we can treat endoscopically. Here, the common bile duct go inside the papilla, but it's not dilated. And even the pancreatic duct is normal, so we don't have any dilation. Okay. You can see here very well the lesion. You see it? And seems to be quite soft at elastography. I think we can decide to remove the scope and to perform ampulectomy. There are any questions from the audience?
We agree. Very nice demonstration, thank you.
Again, the lesion here with the double duct, the common bile duct, the pancreatic duct below. The pancreatic parenchyma is normal, a little bit dishomogeneous, but without any lesion.
Okay, Mara, Dr. Petrone,
Yeah?
can you hear me?
Yes?
So, what's the next step in your room?
We are going to perform ampulectomy now.
It's a little bit strange because there is, you see, a nodule, central nodule, which probably has the orifice located on here. this is, I think, is the orifice. But then, under this fold, which looks normal, there is some tumor spreading here on the lateral edge of the papilla. You see, like an LST, a small LST. So I think I will try to catch everything together, because this is also adenoma here. So I will try to catch the whole papilla, but I'm not sure that once catched everything, this part will come completely off, but we will see. And just in case, we will do a second small resection of the remaining tissues. Now, do you have some contrast here? Yeah. Can you purge the catheter? Okay. So we have some contrast just to see if it's possible to opacify the pancreatic duct, to see and to better recognize the orifice after a resection. A small injection, please. No? I put some drops of indacocarmine in the contrast, which might help to understand. Inject. That's the bile duct. Of course, when you're looking for the pancreas, you always opacify the bile duct and vice versa. This is the Marfilo. Can I have some Buscopan, please? Buscopan? Ah, okay. So I will try once again, but if I'm not able to opacify the pancreas, then we will proceed to papillectomy. Maybe there are two orifices, who knows? Maybe here. Un pochino? See? Let's have a look here. No, this is not an orifice. The only orifice I see is that one, which is a little bit distorted, but this looks to be inject here. Okay. That's definitely the bile duct. Stop. So I think we will proceed directly to papillectomy. Now let's try the oval. Yes, this one. It's a mini loop Acusner from Cook. I'm not sure it will be big enough, but we will try. Okay. Yes. No, mettilo in punto.
Does not look like a typical adenoma, isn't it? Seems to me.
The lateral part, yes. The central part, I agree. It looks a little bit more firm. But the biopsy that were obtained during the preceding examination were positive for adenoma with high-grade dysplasia. So now I will try to put my snare over here, open slowly. No. Very slowly, lentamente. Apri. Devi aprire in maniera progressiva ma continua, perché io devo accompagnare. I have to. Ok, apri. I have to accompany your movement. Apri. Non è tutto aperto. Adesso è tutto aperto. Ok. I try to catch the whole thing. Ok. Adesso chiudi piano piano. Chiudi. Ok. I think I've catch everything. And then we'll see. So now, sì. Now we will do the cut. Nothing happened. I don't know why, but nothing happens. Now, okay. Up, open. We try to collect the piece immediately. Sì.
Sì, sì, fatto aperto.
Chiudi. Aspetta.
Riapro.
Apri.
Sì, aperto.
Chiudi. Piano piano, non troppo perché sennò lo tagli. So this is the piece. Open. Togli l'ansa. And now we will check for hemostasis, and of course we will try to look for the pancreatic duct in order to put a stent. We know that one of the risks of this procedure is acute pancreatitis, and this risk can be minimized by putting a temporary small caliber stent. I usually place a 5 French straight stent or with a single pigtail. Okay. So, see. Now we will check for the resection. There is some edema now because the piece we took out was quite thick, but this I think is normal tissue, what we see on the left side. What do you think? Looks only edema here. You see? So, no. Adesso guide wire. You see here on the flat part of the resection, this is probably the pancreatic duct orifice because the bile duct is probably here. So this one should be the pancreas. But we will see. We will try to cannulate with a guide wire. Of course, in these cases you have to go back in less than 3 months or 3 months. Okay. Out with the guide wire. No, piano. Sì, piano. Fuori. Piano fuori. Vado io poi adesso. Stop. Ancora un pochino. Vai.
Vado.
Sì. X-ray. Yes? Dai. Piano perché questo è il pancreas. This is the pancreas, as I told you. So, no, go into the tail. No.
Vado.
Tail. Perfetto. You stay there. Adesso we leave the guide wire in. Lasciamo la guida. And we will place the stent. And then we will have a look at the bile duct, but I think we don't have to do anything else. Yes?
You don't do any opacification of the pancreas?
No. I know that this is the pancreas because anatomically it's evident, self-evident. So I just place a stent. I don't want to be too traumatic. Yes. We will place a short, 2 centimeter longer single pigtail stent, 5 French, and this is enough to protect, of course not completely, but to reduce the risk of pancreatitis due to thermic trauma. Now we will, place the stent. And then we will have a look at the bile duct. Sometimes if there is a slight dilation of the bile duct and you can still recognize a part of the infundibulum, it might be useful to do a small sphincterotomy to extend the opening of the bile duct. But this is not the rule. I think that in this case, as you can see from the X-ray, the bile duct has been has drained already, so there is no interest in doing something else on the bile duct, and as you can see here, there is bile coming out from the orifice, which is located at 11 o'clock. So in 3 months we have to perform a duodenoscopy and see if there are remaining part of tissue. It's always very difficult to evaluate immediately. Here is the stent coming. Okay, you can remove the guide wire. Remove.
Okay.
Yes. The single pigtail is to avoid migration into the bile duct, into the pancreatic duct.
Okay.
So, is it free? It is free. So now the cannulotome, 1 second, just to have a look at the of the biliary orifice, and then I think we will finish the examination. Any question?
We admire your elegance.
You're a good friend, Fritz. No, senza contrasto. I think that the stent is still partly inside the. I need something bigger, pusher, 10 French, something to push out the stent. Because I had this feeling that the stent was still partly into the channel, and now probably it's now it should be out. No, still didn't. Okay, so I go with something bigger just to be on the safe side. I don't want to displace the stent by removing the scope. Okay. Now it's out. Now it's out. Okay. So just a few seconds to show you the biliary orifice. But I don't think I will do anything else, because radiologically, if you can have a look at the X-ray, you will see that the bile duct is completely. There is no more contrast in the bile duct. So the orifice is here. You see the bile coming out? Okay, so the hemostasis looks good. I hope that this part of the tumor has been also completely removed, the LST part. Apparently, yes, but we have to check in 3 months. Okay.
Excellent.
Okay.
Thank you very much.
Thank you.
Thank you very much, Guido.